Hello, this is Forrest Blocker. This is the fifth part in the series, Cancer, Where Are We Now? Today we're going to be talking about cancer prevention and cancer treatment. So what we found is from 1975 to 2001, the death rate per 100,000 people in the population in 1975 due to heart disease was 320. It has fallen to 180, so almost halved as a direct result of prevention. Cancer, on the other hand, prevention really hasn't helped a whole lot. It has helped somewhat. It sort of peaked here in 1991 and has fallen off since then. And that's primarily due to a combination of two different factors. One is that people don't smoke as much as they used to, and that's a big factor. And then the second factor is the better drugs that we have. So the things that can help with cancer prevention, we saw that you can limit your exposure to carcinogens or cancer-causing things. You can change your diet. You can exercise more. You can think of 4 levels of prevention. Primordial or social prevention, which means avoiding the emergence or establishment of social, economic, cultural patterns of living that are known to contribute to the elevated risk of disease. For example, not having a good diet, being stressed, all of those things contribute to cancer. All cancer caused by tobacco use, obesity, physical inactivity, and heavy alcohol consumption could be prevented completely. In 2007, approximately 20% of U.S. adults were current smokers. The decrease in smoking has been a major factor for the decline of U.S. cancer deaths overall since 1991. Certain cancers are related to infectious agents such as papilloma, hepatitis B, hepatitis C, HIV, and Helicobacter pylori. Many of the 3 million skin cancer cases are diagnosed annually could be prevented by protecting the skin from excessive sun exposure and avoiding indoor tanning.
So using sunscreen?
Using sunscreen or a hat. Primary prevention means controlling the cause and risk factors. Some low-hanging fruit might include the distribution of condoms, which will prevent some of these infections, papillovirus, HIV, even hepatitis. Those can be transmitted sexually, or needle exchange, or vaccine. So there are actually vaccines that can prevent the spread of some of these viruses. So those are good things too. Secondary prevention, that's from the onset of the disease to normal diagnosis. You can develop safe, accurate methods of early curable stage detection. Then the tertiary prevention is reducing ongoing morbidity or mortality once cancer is diagnosed, such as monitoring for early detection of second primary cancer. Screening can prevent cancers by allowing for the detection and removal of precancerous lesions before they metastasize and move all over the body. If you detect cancer early before symptoms appear, it usually results in less extensive treatment and better outcomes. There's different screening patterns for different cancers. A lot of these are controversial because some screening requires a certain amount of radiation. For example, in breast cancer, there's a new breast cancer screening which is more accurate, gives less false positives, and catches more of the small cancers, but it involves twice as much radiation. So this was called in 2011 as the standard of care for breast cancer screening for women above a certain age. Necessarily catch all the tumors. And at the end of the day, what you want to know is, has the screening resulted in fewer women dying of breast cancer? As it turns out, that is a debatable point. With colorectal cancer, the American Cancer Society recommended in the 50s that people over a certain age get digital rectal exams yearly. Other people since then have recommended additional things. With cervical cancer, for 50 years, we've had something called a pap smear, which detects abnormal cells in the cervical wall. And it's still the standard of care. However, as your generation gets the papilloma vaccine, I think cervical cancer will basically be eliminated. We won't have to screen for it because nobody will be getting it. If little boys and little girls all get this vaccine, nobody will get cervical cancer. There's also some screening for rectal cancer, for lung cancer, for skin cancer, testicular cancer. For prostate cancer, it's also somewhat controversial because there are different kinds of prostate cancer. Some prostate cancer can be very aggressive and has to be treated. But really, if men live long enough, just about all men will develop prostate cancer. And most of it will be very, very slow growing. And usually the man will die of something else or old age before the prostate cancer kills him. So the question is, the side effects and the complications of treatment may not always be worth it. It may be better just to leave the guy alone. Okay, so some of the vaccines and chemoprevention. There are approved vaccines for hepatitis B, which causes some types of liver cancer, for papillomavirus, which causes cervical cancer, and for prostate cancer.
There's a typo.
There is a typo.
Human and then types.
Yeah, I should fix that. Should I fix it right now?
No, until later.
Okay. Several other cancer treatment vaccines are currently being tested in large-scale clinical trials, including vaccines for the treatment of non-small cell lung cancer, pancreatic cancer, ovarian cancer, melanoma, and multiple myeloma. Chemoprevention. There are some chemicals that can stop a recurrence or first occurrence. For example, tamoxifen is a drug that is a selective estrogen receptor modulator, and it helps to prevent a recurrence of breast cancer in women who've had breast cancer. There's a similar drug called raloxifene, which is also a selective estrogen receptor modulator, and it also has an effect of reducing recurrence of breast cancer in women who've had breast cancer. And the advantage of this particular drug is that tamoxifen has a tendency to cause another kind of cancer, whereas this one doesn't. So there are pros and cons of both of them. Aspirin actually it's effective at preventing colorectal cancer. It reduces cancer deaths also for esophageal, pancreatic, brain, and lung cancers. There's a delayed but positive effect for several other kinds of cancers as well. People are also working on drugs that are derived from garlic, organic sulfur compounds, vegetable compounds, compound from red wine, and statins. So the evolution of treatment of cancer over the years. Classic cancer therapies target those cells that are rapidly dividing. So one difference, first thing you want to do when you want to figure out how to treat cancer once a person already has cancer, is you want to figure out what is the difference between the cancer cells and the normal cells, because they're all part of you. So one of the differences is the cancer cells divide rapidly. So classically, you just target the cells that divide rapidly as much as you can, and you try to kill more of the cancer than the patient. These classical cancer therapies have many serious adverse effects, side effects. Before 1950, the therapy for cancer was primarily only surgical. So if you had a primary tumor that was just in one place and hadn't metastasized, if you could just cut it out, then you were good to go. Unfortunately, usually by the time cancer is diagnosed, it has spread somewhere else. And one of the interesting things that we found recently is that if you have a primary tumor, let's say it's a kidney cancer, it's called RCC, and you have some of those tumor cells that have started little satellite tumors in other parts of the body, even if you remove the kidney, These are still there, and in fact, they can actually grow more out of control because the primary tumor can be controlling the growth of the satellites. So it's not always the best idea to remove the tumor surgically if you can't get everything. Radiation therapy became a standard of therapy for some cancers after 1960. It had been used well before that, but it became a standard of care after 1960. So the benefit of radiation is that radiation does target more rapidly dividing cells. So you can give somebody whole body radiation to sort of mop up these little satellite dudes. Chemotherapy, the first one was a nitrogen mustard. There are folate analogs such as methotrexate, purine analogs.
Mustard?
Yes, nitrogen mustard.
They would put mustard on people?
Well, nitrogen mustard is a particular kind of chemical. It's actually used as it's a gas that's used in wartime, and that's how it was developed. But it does kill rapidly dividing cells just like radiation does. So that's one of the reasons that it was developed. During the 1980s, the discovery of new chemotherapeutics was slow, expensive, and really what we were producing was a lot of drugs that were very similar to one another with just very small differences. So they were anti-metabolites, alkalites, anti-mitotics, meaning stop cells from dividing, and topoisomerase inhibitors. So up until the 1980s, we were producing a lot of different kinds of drugs, but then all of a sudden we just started producing a lot of the very similar kinds of drugs, very expensive and slow. Then we developed the idea of targeted drugs, where we would target specifically parts of this cell-cell communication. We could target the ligand, we could target the receptor, we could target the transduction pathway, we could target the transcriptional pathway. We'd have drugs that would specifically, maybe in a lot of cases, bind instead of the drug, the chemical that would normally bind, a competitive inhibitor. So growth factors, signal molecules, cell cycle proteins, modulators of apoptosis, and molecules that promoted angiogenesis could be targeted. These drugs need to be metabolically stable, well absorbed after oral administration ideally, and have favorable toxicity profiles. In other words, they shouldn't kill the person or make the person sick. The FDA has approved approximately 30 molecularly targeted agents for cancer-related indications. They target abnormally expressed tumor proteins and receptors, growth pattern or tumor needs, abnormal genes. They have fewer side effects since these therapies are specifically targeted to cancer cells. We talked about Gleevec for the Philadelphia chromosome in chronic myelogenic leukemia treatment as being particularly effective. And then finally there's immunotherapy, which can either be targeted or non-specific.
What does immunotherapy do?
It means that you use the immune system to, you either beef up the patient's natural immune system to attack the tumor, or you use the immune system to target tumor cells specifically. Okay, so chemotherapy is, in this case I'm using the word to talk about conventional chemotherapy. It kills more of the cancer than the patient, and it includes these various different kinds of chemotherapeutics. Okay, they're all poisonous poisons. They're designed to kill cells. Let's go over these. So, non-specific immunotherapy and adjuncts. They don't target the cancer cells specifically, but they stimulate the body's own immune system. They can be cytokines, chemicals made by some immune system cells. For example, interleukins, interferons, and GM-CSF. as F. They can be checkpoints, molecules on immune cells that start an immune system. So PDL1, for example. And others include these other, for example, here, this is a bacteria that can stimulate or activate the immune system. Just basically turn on the immune system. So that's non-specific immunotherapy. Passive or adoptive immunization. Passive immunization, transfer of active antibodies from one individual to another. Short-term immunization. In other words, you know how vaccines work, right? You see a foreign body, your immune system sees a foreign body and builds specific molecules to attack when they see that particular foreign body again. So what you can do is you can take somebody else who's been exposed to that foreign body, take their antibodies and put them in you. And now their antibodies can work for you. Adoptive immunization is the transfer of mature circulating lymphocyte, and it requires matched donors. So if you're
What are lymphocytes?
Lymphocytes are blood cells, white blood cells, which is the main part of the immune system. So active vector immunotherapy stimulates the immune system to attack tumor cells. You can have one or more specific tumor antigens. You can have an engineered virus or other vector. So let's suppose we have an antibody that we want to deliver that's specific to something on a cancer cell. So how do we get that into you? Well, one thing we can do is that we can stick it inside of, or on the outside of, a virus. Because viruses have the very clever natural ability to get their stuff into a cell. Another vector could be just a plasmid. Somehow we want to get that genetic material to make this antibody to go into the cell somehow. And we want it only to go into those cells that are cancerous. So one of those is an adenovirus that's used for drug delivery a lot. So that's the end of part 5, cancer prevention and treatment. Please stay tuned for part 6 of Cancer Where We Are. Where are we now? Thank you.